Again, Angeline here. I'm not going to introduce myself. Today, we are going to talk about pitfalls in any trauma for that matter, but this is specifically abdominal trauma. You must understand in trauma, every minute counts and every sand particle matters. That is your physiology. They will keep building up very silently but rapidly and blow up on your face. So, when I talked about pitfalls, the first thing everybody will think is the pitfalls of non operative management and its risk. Okay, everybody will talk about the non operative management and its risk, but it is much more than that. Have a look. The pitfalls can be right from the time of trauma to your intraoperative to the discharge. I don't know why the photo is not there, a patient getting discharged. The pitfalls can continue even inside his house. You have put a feeding jejunostomy tube and sent him home. That can get dislodged. So you must understand pitfalls are not just NOMs related. They can start off from here. You will understand in a minute how pre-hospital will matter. Okay. So this is the patient who's got discharged. This is just metaphorical. He's all smiles. When he goes home, he can have still problems. Whether it's non-operative management or an operative management, keep it in mind that they are going to have pitfalls there also. So in the pre-hospital care, about the time taken to reach you, about the multiple referrals that they will be having, stabilize impaled foreign bodies, and there's something known as BTLS access. We'll come to all this later. Coming to examination, always look for tenderness away from the stab. At the point of stab, you will find tenderness next 5 centimeter, but always look far off. I'll show a video. Thoracojunctional penetrating injuries, yes, very important. Penetrating wounds in the perineum. Investigations, please send with the full bladder. Don't drain it. In your primary survey, you will not be seeing the urinary output. That is hourly output. This is what was in his bladder already. It did not help you in the resuscitation. So send him with the full bladder. Get the ultrasound if he has to move out and then drain the bladder. Number one. You may need to repeat fast and always unsupervised intra-hospital transfer is a big issue. I understand centers which have a mobile CT and everything. It's okay for them. But if you're going to transfer, please take an escort. Not that an escort can stop bleeding. At least they will make sure that this fragile physiology is not actually manhandled during transfer into the CT gurney. As I told you, gold standard is a serial examination and there should be no hierarchy in your investigations. Now, when it comes to altered consciousness, they may not complain of pain, but tenderness you will elicit. Very many juniors will come and say, sir, his GCS is 8, so I could not elicit tenderness. No, they are wrong. They could not elicit pain in the history. Tenderness will be there. Keep this in mind. So in your pre-op, take stoma consent. Intra-op, make sure lights. The lights is the biggest issue in your trauma abdomen. You'll be operating at 2 o'clock in the night. Junior, most person will be operating most of the time. Your lights need to go into all quadrants and that no automatic light will do. You need somebody there to rotate the light as you move into the quadrants. Very important, especially pelvis. You won't be able to see. The right upper and left upper also you won't be able to see. So be nice, tell the OT staff, please don't leave me till I tell you to go. And most of them listen. You need their help. Pads, very important. Tell staff you might need many pads. Keep them radio tagged. Suction bottles, always keep 2 with you. Whether it is peritonitis or hemoperitoneum, keep 2 bottles. Otherwise, what happens? 1 bottle will fill up in no time, 1 liter. It will be a mess in the theater. Number 2, you will lose count of the amount that has gone into the bottle. And then they'll go and bring the other one or they will wash this. But if you tell them in the beginning only, I want 2 bottles, they always oblige. Now, as I told you, intra, look at both sides. People have missed even on a laparotomy. That is why please tell your assistants if you're elderly, please look for further perforation. If not for the interest of the patient, your juniors will be looking for a perforation just to tease you. They'll say you missed this. There is one there. All that helps in patient outcome actually. So you look at the pad and instrument count. Now, preemptive complications. Look for ILS. How will you look for collection and leak? How? By ILS, by subtle tachycardias. Don't wait for them to become manifest. All the time preemptively look for complications. Sometimes specialties will push you to do a laparotomy, a BK amputation guy with a very minimal free fluid. I know Dr. Jagdish is going to murder me for this, but this sometimes can happen and you'll end up opening the abdomen. One more important thing, any trauma fatality, please check on postmortem and talk to the forensic. It helps a lot. As a trauma surgeon, you need not necessarily go and see the postmortem. It may not be logistically possible. But in fatalities, make sure you go and see the postmortem report or liaise with them or even go there yourself. Now, as I told you, your pitfall can start in the pre-hospital phase. This is our own study done in GH. This patient, blunt injury to the abdomen or other blunt trauma, he takes more than 3 hours to come to us. But you see the ones with the knife sticking out and the wooden rod sticking out. Within an hour, they are with you. Nobody keeps them, including in the road. They will be packed off very quickly. So the pitfall is starting there. In the pre-operative setup itself, they will reach very early to you. These will be coming late. And always stabilize impaled foreign objects. Like this, please put this figure cross and stabilize so that it does not cause more harm. Similarly, this was another iron rod which had pierced the popliteal fossa, gone up to the abdomen and lodged inside very close to the diaphragm, torn the colon. Actually, this was a little obese lady. She was walking on her balcony, a half-built balcony, and she fell onto the centering near Annamalai. This was in PIMS, not my case, but colleague's case. So, always you need to remove this. This can't be going during transfer or into your CT also. So you need some sort of ease to transfer the patient. That is known as access. So you will cut off the protruding ends. Now, when you cut off the protruding ends, you will be probably using some semi-powered drills that will heat up these rods. That will cause more harm to your muscle and other tissues in the limb. So always keep pouring saline at the point of cutting, like the way you use a giggly saw. That is not to transfer the heat, that is for ease of, that is to lessen the friction. But here you keep pouring saline to reduce the heat. And always look at the nearby cavities, like your abdomen problem, look into the thorax. So as I told you, you use an appropriate tool and you will need sedation to remove this. You see, we have removed it. And generated heat to be neutralized. One more thing about ballistics. This a patient who comes, he's saying 5 centimeter knife. His relatives also, or the bystanders, just 5 centimeter. Yes, we believe them. It is 5 centimeter. But if you look at it, it's going to pierce the abdomen. Abdomen is a very, very elastic thing. And number 2, he's going to fall over the knife. So you can find the knife with a 5 centimeter, like the accordion that you play, things can pleat over themselves and go and hit against the sharp end. And this 5 centimeter can even touch the great vessels across the spine. So your blade size should not be, you should not be complacent saying the blade size is only 5 centimeter. Now coming to other cavities. This patient, when they have a penetrating injury to the abdomen, always look into the thorax clinically and imaging. As Dr. Shivanand had said, any CT is a torso CT. It's neither chest nor abdomen. It's a torso CT. Have a look. This patient actually had come with a stab to the epigastrium. And in our primary survey, he came walking. No issues. Not that he was very sick. And when we did a primary survey, we realized there is loss of air entry. So what did the X-ray chest show? Severe hemothorax. In fact, that hemothorax has become a pyothorax now. It's about 72 hours old. So innocuous looking abdominal injury. Don't only concentrate here, move into the next cavity. Similarly, thoracic stab. Yes, you will definitely evaluate the thorax completely, but look into the abdomen also. See, this is a patient with the stab here, almost just lower to the nipple. Absolutely, the thorax was pristine. He had problems only in the abdomen. You see, huge retroperitoneal hematoma almost going into the leaves of the mesentery. So what I want to tell, when there is a stab in one zone, especially in junctional zones between the thorax and the abdomen, look into the other cavity also. So thoracic, look abdomen, abdomen, look chest. One more thing, this is a bulgur to the perineum. Now, don't just look at this injury. There is something known as a toss that can cause more harm. This fellow actually had a ruptured spleen. This is the last of his problem. Only thing is, it's very visual. And everybody going saying bulgur, bulgur. But the main problem was a shattered spleen that you will pick up if you're aware that he can be tossed. And number two, there can be abdominal injuries, and actually you will do your ATLS accordingly and pick it up. So coming to tenderness, I told you pitfalls. Coming to tenderness in the elderly, have a look. This lady again had a bulgur, not bulgur, the bull buttered on her abdomen. You see, hardly any tenderness. You have to really press and get it out of her. There is so much of fat. It's, see, very deep she is having tenderness. Now, without a clinical finding, I cannot be indiscriminately investigating or running with her to laparotomy. Number two, look, especially in obese and the elderly. Now, look at this. As I told you, stab injuries, this put a gauze here, there is a stab. You will find tenderness here, but you need to go away and check whether there is tenderness. With this tenderness, you cannot assume there is an intraperitoneal injury, nor can you run with this patient into the OR. So let's have a look at this video. Definitely tenderness is there. There is no doubt. You can see him wincing. I'm moving away. See, when I moved away, I've come back again to the stab. You can see it second time if you want. Maybe the video was too quick. See, we are not professional photographers. We'll go carrying the mobile on the right hand and using left hand to palpate and trying to capture these photos so that our students get to know these things. I just cannot tell tenderness away from the site unless I show it to them. Okay, fine. Okay, coming to distraction, distracting injuries. See the distractions. These are very, very obvious. Similarly, this hand injury. Now, sometimes this distraction will be picked up by your own colleagues and they'll be harping on that. It's a multidisciplinary team. Your own surgery colleagues will be sitting on the distraction part. And if you have any doubt, please use imaging. Fine. So this is what I wanted to tell. Sometimes your abdominal injury will get pushed down lower in the hierarchy. One, because of distraction. Number two, you won't be able to clinically assess the abdomens. Either there is altered consciousness or sometimes your abdomen will not be available for palpation itself. Where can you put your hand and find out something? This is a fixator. So be liberal in using imaging. This is very important. You can use your ultrasound itself. It will be compatible with all these rods. As I told you, no hierarchy. Kindly go ahead and do a DPL. Also, this has come in the bowel injury. One more thing, intra-op, when you suspect hemoperitoneum or a bowel rupture, everybody, yes, you need to put an incision from the xiphisternum to the symphysis. But when you open the peritoneum, keep a small nick, put a suction there first. Otherwise, the whole thing is opened up. The blood is all over the place. You will lose count of how much blood or how much peritoneal contamination was there. The OT is a mess. The staff will try to find comfort zones in that mess. There is a whole lot of hypothermia. All this fluid will go and stick into the drapes. There is a whole lot of hypothermia. And most important, you will not be able to tell the amount of contamination and the blood loss. So always open up a small portion. Try to suck it out. It won't take more than 2 or 3 minutes. That doesn't matter. And then you open up both planes, both sides, up and down, and then do the rest of the trauma lap. As I told you, look at both sides and then you look at the instrument count. Instrument counts and pad counts are likely to have issues in emergency surgery, more in trauma. Because most of us, you can't help it. You'll be going unprepared. Staff will be unprepared. Always be careful about these things because they are sentinel events at the end of it. As I told you, this is appearing just like this, but then if you see, it's a through and through injury. So call for help. When you have an issue, call for help if available. There's something known as a negative laparotomy. It can be up to 4%. And there's something known as a non-therapeutic laparotomy, which is 9%. You can accept that because that 9% non-therapeutic laparotomy is to save the 91% who really have an issue. So that is acceptable. By universal standards, it's acceptable to have 4% laparotomy, negative laparotomy, and non-therapeutic is when you're not doing any therapy, they're just some abrasions and serosal tears. That can be up to 9 and negative can be up to 4. Now, as I told you, always have preemptive complications. If your patient is here, you as a surgeon should be sitting here, not with your vitals. But if you sit here, you will pick up when he's traveling along this bad trajectory. The problem is most of us stay where the patient is staying. We don't go look forward. Always go forward and look whether your patient is following you. You're likely to pick up small things. Not small things, you're likely to pick up early things. So keep that in mind. If you have operated, this probably is, it holds good in every surgery, more so in trauma. Move one step further in the spectrum, stand there, see whether your patient is following you. If he does not follow you, you're happy, patient is happy, and you can bless yourself. As I told you, they are man-made anatomical boundaries. Textbooks are compelled to address blunt injury in isolation because they need a fair amount of comprehension. But in ground reality, you can have problems. Like you've done everything properly in the abdomen, but your lungs are slowly going downhill. Keep an eye. Don't outsource that to the physicians. Don't outsource that to the intensive care people. After all, they are your patient. You can take the help, but don't outsource complete that, including diagnosis. They will preemptively look into it. There are other things to do also. Have a look. Please follow up the postmortem. Network with your forensic medicine colleagues. Patients can teach you even after they are no more. Have a look. This patient has come incident 1 hour ago. PIMS has a lot of that fisherman community very close by. They keep quarreling with each other. He was stabbed and he was brought within 1 hour. It's a possibility. They can come to your A&E within 1 hour. But he was brought in extremis and he died. This bowel is ruptured and hanging out. Now, we know that this bowel could not have caused the immediate death. He's come within 1 hour. He has a stab here on the right iliac fossa. The right side stab had pierced the IVC. This is the idea of checking on the postmortem. Not that you must go to postmortem. This is the idea of checking on the postmortem. One case you see, next time this will be in your mind. You can say, no, within 1 hour he could have died. I have personally noted the postmortem reports when you get a next similar case. Now, coming to damage control surgery, we keep talking about it. There needs to be a balance. It's very important that you have a balance. So either you go and do damage control for everybody. So you have not given him a chance of less morbidity, or you didn't do a damage control on deserving people and you kill them in the process. So there is something, how do you find a balance objectively? There is something known as scorings. We will not go again into the details. So trauma is time sensitive. Trauma is time sensitive. Physiological response may not be uniform across the board. I told you. Patients can present anywhere in the spectrum. As I told you, that chap with a mobile phone and this one with the evascularization who almost went through us into the postmortem room. So what about the skills available in the facility? As I told you, institutional protocols need to improve with each trauma fatality. That is very important. Now, we usually talk about rehab in limb injuries or in head injuries, but when it comes to abdominal trauma, we don't talk about rehab. There is a little role for them. See this patient. He has a tracheostomy there that has to get weaned off. He had a very serious liver injury that has to get weaned off. Not only that, he's not very catatonic. He hardly had muscle strength to breathe on his own. So all those things need a bit of rehab. One more thing, you will be pushed around. So for that, have networking. Very, very important. Your neurosurgeon or radiologist may, however disturbing the imaging report, your only weapon to prevent a negative laparotomy is your clinical findings. Sometimes neurosurgeons, they will find distension, that will be because of ileus, but they will say there is an abdominal injury. Don't take already sick patients and go and open the abdomen. Why not be at least 90% sure with your imaging, with your clinical findings, with your experience, and avoid it? Whatever it is, your clinical examination always comes in handy. Very important. Sometimes there can be pressure from the ICU, especially for closure of a laparotomy or to delay the enteral feeds or to start parenteral feeds. The dietitian will insist that you start parenteral feeds. Then the ICU doctor also will say start parenteral feeds. Within 72 hours, nothing will happen to his nutrition. Don't be in a hurry because somebody pushed you to do something with which will land up with unwanted, something not indicated is contraindicated in a patient. Especially closure of a laparostomy. Look at this laparostomy. This whole abdomen was outside. This was also a liver injury. So much of edema, we had to keep it out. Invariably, the attenders, patient cannot, poor thing, he is at the mercy. Your ICU staff, because it's such a visually disturbing people who are not initiated to a laparostomy, they will keep insisting to close it. And if you ask them why, they will put the blame on the attenders. They will say, attender told to, it would be better to close. So I know this vicious circle there. We have worked in enough trauma issues. Hold your ground. By going and closing this, don't kill off patients. So as I told you, clinical examination may not be sensitive, but a serial clinical examination can get you there. Now coming to again AI, there are some AI applications. One is your trauma care AI. It is mainly, it gets integrated into the electronic health record. There is something for rib fractures and there is something for clinically. This is the only thing which is clinically deployed. This is in the US. In India, there is not much for trauma I've seen. For cardiac arrest, it is employed. That's all in one hospital in Hyderabad. So this is clinically deployed now. So that is about AI. Now in trauma, your leadership skills or rather your soft skills will be put to test, and you can also develop your soft skills like leadership. See this resuscitation going on. You need to be a leader there, and to be a leader, you need to be competent for the level that you are in. Suppose you're a junior resident, you must have that much of competence. You're a senior resident, that much level, a consultant, that much level. They should not be below that competency required of that particular cadre. Communication. Once you're a good leader, automatically communication and the rest will come. So if you really look at it, it is the competency that matters. You have competency, automatically these factors will fall in place, and keep networking with the others. The interventional radiologist I just now told you, or your gastroenterologist, or you're doing a definitive repair of the liver injury which has got a hilar disruption, you might need the surgical gastroenterologist and a whole lot of things. So this is where your teamwork comes, and the teamwork cannot come overnight in this situation. That has to be done many years earlier or many weeks earlier. That teamwork should be in place. So now what has happened? Previously, all abdominal trauma mandatory laparotomy. Now it has started coming to non-operative. Now, even when there is a blush, if you have enough expertise available to sit on the patient, they don't do anything. So this is how the trend is going on in abdominal injury. We are not talking about bowel injury. We are talking about abdominal injury as a whole. So apart from the core clinical works, to strive towards thumbs up from your patients, please do your audit and research also. This is one of our liver patients. He's giving us a thumbs up. And even this master class is towards improving trauma patient care. Now, what has happened? 2 trauma surgeons, they are doing the EFAS, most of them. Do they also have to enter the IR? It's debatable. Thank God Dr. Shivanand is not there. But there is a push to ask them to do some sort of training in IR so that you can do the IR part without, probably overworking the radiologists. This is just in the discussion and probably in pilot projects. So now if this particular presentation, the audience and students have come out with a clear understanding about the possible pitfalls, then injured patients will be real beneficiaries of this presentation. Thank you all very much. I'll be happy to take questions. Any questions? Any questions? Jagdish, any question? Vijay Kumar sir, thank you. You came today.
Nothing, ma'am.
Very much,
Lovely
sir.
presentation, completely from experience. So it was education by itself listening to it.
Thank you so much,
Fantastic
Jagdish.
presentation, ma'am. It's all experience, and the presentation dips into what you have done over the years. Very educative.
Thank you so much, Jagdish, and thanks for coming all over today.
Sure, ma'am. Thank you. I got late because of the office work, but then I think
no issues. I understand, Jagdish. I understand, and thank you again very much. Vijay Kumar sir, any question? Vijay Kumar sir, any question?
No, madam. It was a very good lecture, madam.
Thank you very much, sir. Again, thank you all very much. Please do enter the WhatsApp group. It will be very helpful. Thank you again. Thanks, Pinesh. And thank you, Professor sir. Thank you very much, V.K. Professor sir.